everyone. Gagandeep, so we can start.
Yes, ma'am, we can. Hi. Hi, everyone. Good afternoon. Good afternoon. There's a good gathering today, right? So let us begin. So the topic of today's lecture is the art, craft, and science of maxillary basal implantology. Right? This is going to be presented by me. I am Dr. Gagandeep Gauba. I am a basal implantologist based in Punjab. Right? And now let us begin. So, how does a typical implant patient visit a dental practice? Right? He is going to be missing a single or multiple tooth that are already missing or are indicated for extraction due to various reasons and need to be replaced. This is a typical presentation of a patient approaching us for a dental implant. But today we will be only studying the implantology in the maxilla. As you can see, this is the diagram of the maxilla. This is not much importance to us. We already know these things. So what are the various clinical presentations requiring intervention in basal implantology? Either the patient could be missing a single tooth, or patient could be missing multiple tooth that might be adjacent or non-adjacent, or there might be a segmental rehab, like whole posterior segment is missing or a whole anterior segment is missing, or in worst case scenarios a patient might be visiting us for a full mouth rehab, that is the patient has no teeth in his upper jaw or all the teeth are needed to be extracted, right? So, what are the problems involved in training the maxillary arch? I want to ask you all this question. I want to listen. What are the problems that you guys are facing in your practice while treating the maxillary arch? You can unmute your mic one by one, and please answer this question if you want to. Dr. Simmer, do you want to answer
Hello.
this question?
Hello,
Yes.
sir.
Hi, doctor.
Hello, sir. Not
Dr.
problem.
Abhay from Nagpur.
Hi, Dr. Abhay.
Sir, I am doing basal implants also, but while doing maxillary arch, if there is knife edge, it's very difficult to
Right,
load. Plus, and it's very difficult to bend the implants.
right.
It's
So
very
I will be
scary.
asking.
Like
Right.
today only I did two laterals and two centrals, but the size
Right,
of the implant was like 3.5 by 17. So that
right.
implant are very difficult to bend. Once you try to
Right.
bend, the patient is old age, like she was like 72 years of age, and while trying to bending
The bone
the
fractures, right.
palatal bone, I feel that palatal bone थोड़ा सा fracture हो गया हल्का. Still the
Right. So,
implant is stable.
so one is a knife edge ridge, right? Dr. Simmer, you were
Knife edge
saying
reach.
something?
और
Uh,
sir, then बाकी सब
Not now,
implants
sir.
ठीक है.
I'll keep my
So
questions for that.
what should we do in these cases?
Sir, this will be answered in the presentation. I am just asking what are the problems we face. So we will discuss it in the coming slides. You can please mute your mic, Dr. Simmer.
Yeah, sure, sir.
And
Yes,
right,
sir.
sir. What are the problems you were telling about?
So the main problem is in the sinus area.
Sinus area, sinus pneumatization. That is one of a very big
Yeah.
problem. Again, anyone else?
Especially it's a single tooth with where the maxillary sinus is very low. So that is a bit of a problem.
Right. Sinus pneumatization is a problem. Any other? Anyone else want to say something?
Yes,
Dr.
sir.
Hatim, please.
Thank you. Well, I have a problem in immediate implants, especially in the anterior region.
Right. And why was this problem? Because of the anatomy of the region or because of the bone density?
Well, actually, the cause in the immediate loading is that the patients, they do require an immediate restoration, which
Right.
may cause a short-term failure.
Right. So we will be answering this also. Right. Again, any
Mm.
other? So let us move on. So what are the problems that I felt before I switched on to basal implantology? These were the problems that I was facing. One is the primarily is the anatomical problems, that is knife edge ridge, because of the residual ridge resorption. As we have seen, when the tooth is extracted, the ridge slowly resorbed and turns into a knife edge ridge, and later on that knife edge also resorbs, and we are only left with the basal cortical, right? And there are some physiological problems also, like Dr. Simmer said, sinus pneumatization. And like Dr. Abhay said, because of the low bone density, when you try to bend the implant, the bone fractures. There's a crackling sound of the bone, and immediately, if you get a very good torque now, when you bend the implant, what you will see, the torque is gone. The torque is all lost because the bone has fractured around the implant, right? And other problems are bone resorption in vertically, and this might be because of physiological resorption and also due to pathological reasons, like because of severe periodontitis. When patient comes to us in this condition, the vertical bone is largely lost and we are left with very less bone. And in basal implantology, we have answers to all these questions. And like Dr. Hamid said, in immediate loading also, I will be also answering this question in the coming slides. And pneumatization we have talked, like we can see here, the sinus is pneumatized till the alveolar crest only. We are only left with 2 to 3 bone. So what to do in these situations? So firstly, we should understand what is our aim as a basal implantologist. What do we want to achieve when we get into basal implantology? What is our achievement? What is our aim? What are goals we are focusing our aim on? These are bilateral chewing capacity with balanced occlusion. We want to restore the patient with a bilateral chewing capacity and a balanced occlusion bilaterally, right? We need that the patient has all the teeth till the first molar in the arch, right? This is our first aim. Second aim is we need reasonable aesthetics. We need good aesthetics, that the teeth that we place, if we are doing anterior segment or we are doing full mouth restoration, the aesthetics should be reasonable and the patient should be satisfied with the aesthetics, right? And we want a long lasting and a stable solution. We don't want any bone augmentation like bone grafting, sinus lift, or alveoplasty. Neither we want to add any artificial bone, neither we want to remove any natural bone that is present. That is one of our aim as basal implantologists. And one the most important is no cantilever hygienic prosthesis. That is, our prosthesis should not have any cantilever because they are very detrimental to the bone in the maxilla. Since the bone is the maxilla is very soft, right? When we anchor the implant, even if we anchor sufficient number of implant and we leave a large cantilever, there will be lateral forces that won't be dissipated adequately, and hence they will lead to inadvertently will lead to the implant failure and crater like bone loss around the implants. So this is our aim as basal implantologists, that we want to achieve these 5 goals. Okay. Now we are moving on to the next slide. A very important note I want to bring in front of you is that basal implantology is the prosthetically driven discipline. We should understand that many of the people think that basal implantology is a oral surgery based discipline because the fundamental principles of basal implantology are derived from orthopedics and also traumatology. But this is a prosthetically driven principle. What we have done is we have adapted the principles from orthopedics and traumatology and brought it into the dentistry, right? So the patient comes to us for having a teeth, not for the implant. It is us that tell the patient that go for an implant because implant will provide a better solution. But the patient only wants a good set of teeth. Okay, and basal implantology is based upon clearly dictated rules for surgical and prosthetic part of the treatment. There are very clinically and clearly derived protocols in basal implantology that should be followed religiously, because basal implantology is a very technically sensitive science. If we don't follow the rules and regulations adequately to the point, we are bound to failure. Even if we place implants very good and our prostheses are very bad, the implants are bound to fail because of the bad prosthesis. We should understand this, and everything should be done very carefully and in accordance to the rules of basal implantology that are based upon the rules of orthopedics and traumatology. So, what are the treatment protocols in basal implantology? Basal implantology provides us a lot of treatment protocols, a few of which I will discuss in this webinar. The first are the standard treatment protocols. Okay, there are certain standard treatment protocols that are universally applicable, or I will say at least in 98% of cases, these protocols are applicable, right? In standard treatment protocols, we have standard full arch rehab, we have standard segmental repairs, and we have the standard modification of both of these, right? So these are standard treatment protocols, and apart from that, we can customize these plannings according to the patient, like the demands of the patient and the anatomical features, what are the bone quality and what are the shape of the bone present. So we can customize these solution, but these custom planning are not part of the standard treatment protocols, right? So we will be discussing the standard treatment protocols. So the standard treatment configurations provided in basal implantology are: number one, standard segments, right? There are three segments in our maxilla. One is the posterior segment, anterior segment, and another posterior segment. I think my slide is not visible. Is there any problem?
It is visible.
Visible? Right. It is not visible to me. So
It's not visible.
it's not visible now.
Yeah.
Now it's coming. So it's visible now, na?
Yes.
Yes, sir.
Yes.
It's
Okay.
visible.
So there are three standard segments. One is the anterior segment, that is from canine to canine, and there are two posterior segments on both sides from premolar, that includes premolar and molar. Apart from that, there are full arch, full arch. Sorry, doctor.
The slide is not visible.
Slide is not. I think it's coming. My side still it's on. It's visible to me on the
It
other.
is visible, sir. It is
PC.
visible.
Okay.
It is visible. I think so. There's some network connection from your side, Gagandeep sir.
No, I don't think so. There is network trouble from my side.
Either the video is operating
Now
or
it's
Yeah, your
gone
video is
for
also getting
others.
little.
It's visible now. So we will be
Yes, it
continuing.
is visible.
It's
Yeah.
visible, sir.
So
Yeah, Dr. Gagan, it's visible now.
right. So we are continuing now. So I have talked about the standard segments and one anterior and two posterior segments, a full arch treatment configuration, and there are also standard modification that can be done within these rules and regulation, not violating these standards, right? So we'll be studying these one by one. So this is a standard full arch configuration in basal implantology, right? So what we can see here is four implants on each side in the premaxilla, anterior to the sinus, maxillary, anterior to the maxillary sinus. We place eight implants, right? Four on each side, four in the first quadrant, four in the second quadrant, and we place two pterygoids distally, okay, to avoid the cantilever, right? It's clear. And there is a modification in case the sinus is pneumatized very anteriorly till the canine, and there is no bone available to place the fourth implant here and here. So in that case, what we can do is we will place double pterygoids. Why double pterygoids? Because of load bearing? No, eight implants. Eight implants are more than enough to stabilize the prosthesis in the maxilla. Okay, in here also, in case of four implants, we can place three implants anteriorly, right? And distal most implant should be and just anterior to the maxillary sinus. Why? Because the aim is to reduce the inter-implant distance. The inter-implant distance should be as low as possible to prevent the fracture of the prosthesis, not for the implants. So in this case, if we place three implants and the sinus is pneumatized till the canine, so what will happen if we place only one pterygoid? The inter-implant distance will be very high, and there will be a chances of fracturing of the prosthesis or overloading of the distal most implant. In this case, to reduce this jumping distance, what we will do is we will place double pterygoid, and the distance between the last implant implant in the anteriorly and the first implant posteriorly will get reduced because of double pterygoid. So this is the rationale of placing double pterygoid. This will also be discussed in the coming slides. And this is the standard posterior segment. In this case, we place two implants in the premolar region and one implant in the tuberosity pterygoid region, right? So this is the standard segment for the posterior, and this is a modification. This is a modification. We can see the sinus is pneumatized, and what we can do is we will place one implant anteriorly and we will place double pterygoid implants, right? And if the sinus is pneumatized distally also, we can place a pterygoid implants transsinus also, because the basal implants are smooth surface implants. They are safe to place in the transsinus route also. And this is the standard anterior segment. Here we will place 4 implants for placing a bridge of canine to canine. For 6 teeth, we only need 4 implants in the anterior segment anchored in the nasal cortical bone. Right? And there is an important concept in basal implantology is deliberate extension of the edentulous space. So we will discuss it in the diagram. Like we can see here, the patient is missing all the molars bilaterally, right? Everyone can appreciate that. And the sinus has pneumatized till the alveolar cleft. So in basal, in what are the options left? If we want to restore only the molars, we cannot do it in basal implantology in this case. In this case, if we want to practice the basal implantology, we have to extract the premolars also and then do the two implants standard segment rehab. That is what we have done is we have converted a zone 3 rehabilitation to a zone 2 zone 3 rehabilitation. So this is a rationale of the deliberate extension of the edentulous space, because if we want to do it without the extractions, deliberate extractions of the premolars, we have to do the sinus lift and bone grafting in this area. That will add to the cost of the treatment. That will also increase the risk of the patient. That will also increase the chance of the treatment failure, because whenever the bone grafts comes in, the predictability of the treatment goes out of the window, because we are wholly solely relying on the bone graft to get taken up by the body, to get integrated, and then we will place the implant. In addition to that, the time will also increase. First we will do the sinus lift, then we have to wait for some while, because there the bone is less than 5 millimeter. We can't do the immediate implant with sinus lift. So we will do a sinus lift, we will do the bone grafting, then wait for 3 to 6 months, then do the implant, then wait for the implant to osseointegrate for 3 to 6 months again, and ultimately the treatment will extend to 6 months to 1 year. Right? So in basal implantology, we have answered to this, and since the bone grafting is contraindicated in basal implantology, so what we will do is we will extract these premolars and convert this posterior zone 3 rehabilitation to a standard segmental repair, because there is always bone in the premolar and canine region. So this is the rationale behind the deliberate extension. Dr. Azuruddin, the single implant prosthesis will be covered in the later coming slides. Everything is covered in the maxilla. Okay, so we have to wait for a while, right? So everyone, it's clear that we have to deliberately extend the edentulous space in sometimes in basal implantology. Do anyone has any question regarding this? Yes, doctor, you can unmute your mic and please answer the please ask the question.
So what about two regions, sir?
Sir, everything is coming. I am just a bit now. I am telling the standard the standard implant configurations. Okay, we are talking about standard implant configurations, and the other things we are other doctors are asking also. These are the modifications. So these will be coming in the later on the slides. Can we place implant and teeth in a bridge? Yes, we can place implant and teeth in a bridge, but that will be covered in the prosthetic part. Today we will studying the basal implantology, how to place the implants and where to place the implants. Right? So anyone has any doubt in deliberate extension of the edentulous span? No? So I'm moving to the
Dr.
next slide.
Gagandeep, sir. Let's do one
Right?
thing. We'll
Yes,
keep
ma'am?
the questions in the end. Yeah.
Okay, ma'am. Sure. Ma'am, I was just asking if there is any important question, na?
Okay.
Because everything is based upon this topic only that in the coming
Okay.
slides. So if someone has a doubt, na, he won't be able to understand.
Okay. Sure.
Okay. So views on retaining the natural teeth. So like we have talked about the aims, our aim as a basal implantologist is to restore the bilateral chewing capacity of the patient, right? And for restoring the bilateral chewing capacity, the retentions of the natural teeth is not at all required. We can also restore the bilateral chewing without the teeth through implants. And in certain cases, you might all have seen, if you are doing a full arch prosthesis, retaining some teeth uh, possesses makes it worse. It becomes very difficult to treat the case both in the anatomical and aesthetic point of view. Also, if the patient has crooked teeth, you have to correct them, you have to cap all the teeth, so this becomes unviable. So in basal implantology, to place the implant, we extract the teeth and to restore the bilateral chewing capacity. So the question was, one other doctor also asked that they do not extract the premolar; they take support from the premolar. So this is the I am going to answer these questions in the following slides. So should we always deliberately extend the edentulous span? How do we decide when to? This is a very important topic. So the following things should be considered when we are planning for the treatment. One is the length of the edentulous span, which teeth are missing, and then we will see the condition of the adjacent teeth. Sometimes you might have seen the adjacent teeth are already having some pathology, they are carious and they are mobile, they are periodontally involved. So sometimes they are already indicated for extraction. Like the case I showed you, the premolars were already periodontally involved. In this case, the premolars, as you can see, there is severe bone loss. There is a grade 2, grade 3 bone loss bilaterally. And here we can see the premolar are both carious, very grossly carious. So here the decision to extract the teeth becomes very simple. The teeth are already lost. So what I will do is I will do the root canals, I will place the cap, and at some point in the future, the teeth will again have to be extracted, right? So in these cases, it's better to extract it in the future. I extract it today and give the patient a long lasting, a standard treatment configuration that is bound to succeed in the longer run, because these are tried and tested configurations, right? And other is the anterior extent of the pneumatization. We have to see that on till what extent is the sinus pneumatized. And in thirdly, we have to see the vertical remaining dental alveolus, right below the sinus floor. How much height of the alveolar bone is present below the sinus floor? We can all see this in the OPG or a CBCT, right? So this is my protocol that I follow on my clinic, right? So we will be studying this protocol in the following headings. First is the single tooth replacement. Somebody asked also what to do in a single tooth replacement, right? So we will be studying this in the following heads, that is in zone 1, in zone 2, and in zone 3, right? And in addition to that, we will be studying multiple tooth replacements and segmental repairs in zone 1, in zone 2, in zone 3, and zone 2, zone 3 combined. In addition to that, we will be studying the multi-segment repair, when the patient comes to us for a repair of more than one segment. That is, many of times you have seen the cases that their anterior, the canine to canine are present and are healthy, and we only have to restore the posterior segments, right? So we will be studying this one by one. So firstly, we will be talking about single tooth replacement in the maxillary zone 1, that is in the canine to canine region. So in this case, what we will do is we will place a single implant in the nasal cortical engagement, and we will not deliberately extract any of the teeth adjacent to it if they are not otherwise indicated for extraction, right? And what I follow at my clinic is one implant, even if basal, for one tooth replacement. I don't do two implants for single tooth replacement. Anyone has question regarding this? Single tooth and single implant or two implant in single tooth replacement. Yes, please unmute your mic, sir. Ask the question.
So in case of anterior central
Mm-hmm.
incisor, replacement of central incisors, the
Right,
width of
right.
the tooth is more, and the water the implant
Mm-hmm.
we are using is small. How to compensate that?
Sir, can you repeat the question?
Sir, while replacing the anterior segment of the
Mm-hmm.
central incisors, in
Right.
case of you are replacing central incisors, you will place a
Mm-hmm.
single implant over there. It won't cover the
Right.
complete area of the width of the anterior teeth, no?
Right.
So how to compensate that thing?
So that has to be done in the prosthetic phase. That has to be compensated in the prosthetic phase. We place the implant slightly subgingivally, and then we place the prosthesis, make a hygienic prosthesis with the convex intaglio surface, right? In that case, it's managed. The extraction space is covered wholly, right? So we will be moving on to the next slide. The next is the single tooth replacement in the zone 2. The zone 2 involves the first and second premolar, right? So in replacement of the first premolar, if the sinus is not heavily pneumatized, which rarely happens, we will engage the implant in the nasal cortex or anterior wall of the maxillary sinus, right? But if the sinus is heavily pneumatized, if the sinus is coming till the premolar, uh, sir, can you please unmute your, mute your mic? The disturbance is coming. Thank you. So when the sinus is pneumatized heavily, then we do the canine bypass. Right here we can see in replacement of the first premolar, if what we can do is we have two options. First option is either we can do the nasal cortical engagement if sinus is not pneumatized. If sinus is pneumatized and sufficient bone height is present beyond the apex of the premolar, what we can do is we can anchor the implant in the anterior wall or the floor of the maxillary sinus. Or if sinus is severely pneumatized, what we can do is we can do the implant in a canine bypass technique. In canine bypass, what we do is we place the implant above the apex of the canine root, engaging the nasal cortical floor above the canine, not above the premolar. So this is a canine bypass, right? And replacement of the second premolar, if sinus is not heavily pneumatized, then similarly what we were doing in the case of first premolar, we will do in the second premolar, we will engage the floor of the sinus, right? But if the sinus is heavily pneumatized and there is no bone above the apex of the tooth, in this case we have to deliberately extend the edentulous space, but it is not an ideal idea. It is not very ideal. So we can, if the adjacent teeth are healthy, we can go with the conventional bridge. Okay, I use bridge in my practice very frequently. In those cases in which the implants are not possible, don't try to overdo the implants, right? We can still take the help of a bridge. We can see in the following slides, like in this case, if the vertical bone height is present, I can place the implant. If the vertical bone height is not present, sinus is pneumatized, and I only have to replace a single tooth, go with a bridge. Bridge is a good option in these cases, right? So, any question till now?
Sir, how do you get the rotational control in single tooth implant
Sir, can you
using a
please
single
stop sharing
implant?
the screen? My presentation is not visible, I think. Nishan, can you please pin my
Let
presentation?
me, yes, let me just do it. Just give me a second.
Sir, how do you get rotational control in single implant?
Sir, your question is not clear. Can you please type the question? Sir, you type the question. I am moving on to the next slide. I will answer in the following slides, right?
Okay.
So, everyone else is clear? Is there any other doubt? Right, so I'm moving on to the next slide. So, when replacing a single tooth in maxillary zone 3, that is the first and second molar region. So there is an important note that tooth number 18 and 28 are not considered even if present, if even if for segmental repair doing a pterygoid implant, they should be preemptively extracted, right? The third molar are not to be considered when making the treatment plan. So I'm placing a cross here and a cross here. So we will be only dealing with the replacement of first and second molar, primarily with the first molar, because restoring up till first molar gives patient bilateral chewing capacity. The second molar is not that much required, but if we want to, we can replace the second molar also, right? So the protocol of doing the single tooth replacement in zone 3, there are three treatment possibilities, right? If we are doing a healed socket, right, the patient comes to us for already missing teeth and the socket has already healed, so the width of the bone, enough bone is always available in the molar region, right? The thing is about height. If there is enough height present, at least 5 millimeter, what we can do is we can place a wide diameter basal implant, the various X that can be placed in this region, right? And engaging the floor of the maxillary sinus, right? If this is not possible, right, if this is not possible, the floor has pneumatized very low and the implant placement is not possible, what we can do is we can subjugate the segment, we can do the prophylactic extractions. Like here we can see this tooth is also carious, the tooth was tender, the third molar we can extract, it was also carious, we can extract for placing the pterygoid, and this premolar also is carious and was infected, right? So we can, what we can do is we can deliberately extend the edentulous space and restore the whole segment. Otherwise we can engage the sinus floor or we can go with the bridge. But in extraction sockets, the thing becomes very easier, because in basal implantology, the extraction sockets we can very easily treat. What we can do is we can place two implants in the extraction socket. We can place a large diameter implant in the palatal root, and we can place a less diameter implant in the mesiobuccal or distobuccal root. So in this way, the two implants will bear the load of the molar and will suffice for the restoration, right? And in this case, like we have seen these cases, there is no bone height available. In this case, there is only one option available, that is a bridge or we can extend the edentulous span. Okay, we can extract the anterior and posterior teeth and convert it into a standard segmental repair, right? Any other questions till now?
Sir, excuse me.
Right, sir.
Sir, in the molar region,
Mm-hmm.
large implants has to be placed on the buccal side or a palatal side, sir?
Sir, in extraction socket and heel socket,
Extraction sockets.
the large diameter, at least 5.5 mm implant should be placed in the palatal socket, and
Okay.
3.5 mm implant should be placed in the mesiobuccal or distal buccal root socket.
Okay, okay. Thank you, sir.
Right. Any other question? I'm moving on to the next slide. So this was, we talked about the single tooth replacement, right? In single tooth replacement, except for the zone 3, we don't have any problem, except when we are treating a single molar, there is no trouble. Here we can do a bridge or we can deliberately extend the segment, right? When we are treating a multiple tooth replacement, right, in zone 1, what we can do is the teeth that are to be extracted should be extracted and implant should be placed engaging the nasal cortical, right? The implant should be engaged in the nasal cortical, one implant for each tooth, even if this, like in this case, the central was indicated for extraction and the canine was indicated for extraction, the lateral was healthy, so I don't extract the lateral, I retain the lateral, and if the need arises I will replace it in the future, right? So we can place single implant for each tooth. We don't have to deliberately extend the segment. In zone 2, when we have to replace both the premolars, we have two options. Either we can engage, like I have told you in the previous slide, in single tooth replacement, we can engage the nasal cortical floor, we can take the anchorage from the anterior wall of the sinus, or we can do both. Like in this case we have seen is this is a tornado, this is a smooth surface compressive implant with Bonenkar. We will be talking about this in the coming slides, right? And this is a basal various implant. So I have placed this implant in the canine bypass fashion. So this is one of the configurations, standard configurations that we can see, right? Zone 2 is clear. When we have to replace both the premolars, we can easily replace both the premolars. We don't have to deliberately extract the teeth and convert it into a segmental repair. We don't have to. Deliberate extension of edentulous span is almost always required when treating the zone 3 multiple tooth replacement. When we have to replace more than one molar, right? In this case, we are replacing more than one molar. This molar was indicated for extraction because of failed root canal, right? This third molar is also indicated for extraction because of the carious region. So what I will do is I will deliberately extend this molar and the premolars and convert it into a segmental repair. Treating the case in such a manner
Screen is not
always.
visible. Screen
Any
is
question,
not
sir?
Screen is not visible.
I think this screen is visible, sir. It might be your network connection.
Is it visible? It is not visible for anyone?
No, it's
It's
visible.
visible, man.
It's
Oh,
visible.
sir, please, can you check
You
your
can see.
network issue? There might be some internet issue.
It's visible.
Please continue. Please.
Visible also.
Right. So in when replacing the maxillary multiple molars in zone 3, we almost deliberately extend and convert it into segmental repair because it gives a very long lasting and permanent solution to the patient. In addition to that, the segmental repair, if we do now, we can easily convert it into a full arch prosthesis later on when the needs arises. When the other segments also fail, these implants, when once placed in the strategic positions, can be used in the full arch prosthesis as well, right? So in this case, this is how we deliberately extend the segment, right? So in multi-segment repair, if the patient comes for a multi-segment repair, right? If the patient is coming for two segments, like the commonly we might have seen this thing in our practices that the patient has canine to canine, the patient has his own, and the patient asks if that can be saved. And what we do is we do the root canals, we do the caps. In this case also, if the teeth are not in very healthy position, we should deliberately convert into a full arch prosthesis. We should extract the teeth and convert into a full arch prosthesis, because what will happen is the sinus is very highly pneumatized anteriorly, and we will have to do the implants in a canine bypass position, right? We will take the bone from the canine, we will take anchorage from here, right? And when the anterior segment, the anterior six teeth fails, what will happen? We have to place the implant here. So because the bypass, the implant will be not be placeable in this region, and we have to remove these implants, replace them, place the implants in the anterior region, and then do the full mouth. So in these cases, if we see that if the teeth will not be retained for more than 5 to 6 years and all have to be root canal treated, in that case what we'll be doing is we will also be extracting the anterior segment and do the patient as a full arch prosthesis, full arch case, right? So I'm moving on to next section. Any other doubt till now? Any other doubt, sir?
Hello.
Yes, sir.
Sir, what if we lost some torque?
In what case, sir?
Maxillary anterior region. What if we lost some torque? It's like
Sir,
less than grade 1 mobility, less than grade 1.
Sir, while placing the implant or afterwards?
While placing the implants.
Sir, which implant are you using?
Sir, I am using compressive implants.
Sir, you should use basal implants. Na? We are talking about basal implantology. Because in compressive implants, we are not able to anchor the nasal cortical, right? We are not able to anchor the nasal cortical. So, because in the anterior region, anchoring of nasal cortical is very easily done. So, we should always stick to the smooth surface implants, and these are proven to be better replacement in the maxillary area.
Okay. But what if he lost the torque? A little bit
Sir,
of torque.
In case of loss of torque, doc, what has to be done is that you check your implant size and switch on to a immediate larger diameter of your compressive implant, whichever you are using, and then you see whether you are getting adequate torque or not.
but sir,
And
these things are not required if you are going with basal
if you
implants.
are
Na,
doing
you
cortical, simple cortical,
sir,
then you won't need to do this. But if you are doing compressive, then you might need to change to a larger diameter.
Okay.
Sir, can you please mute him? Any other questions, sir? So
Please
sir, I prefer using basal implants in the maxilla, right? Because most of the time, what we will see is because the buccal wall defects are present in the maxillary region, and to account for that we have to graft the bone and all these. So the my preference of implants in the maxilla are the basal implants anchoring the nasal cortical when I'm doing the zone 1 rehabilitations. So I always go with basal implants, and these have a proven track record. Plus the implant I am using is the basal varios. This is a very good implant. It has both we will studying this in the later on slides. I can show you. This is the basal varios implant, right? So what is being done here? These have two type of threads. One are the cortical threads on the apex, and the compressive threads, the four compressive threads beyond that. So what happens is, even if we are not able to achieve the anchorage with these cortical threads, we will push the implant further in the nasal cortical, and what will happen is, through the compressive action of these threads, compressive threads, we will sure shot achieve the anchorage in the nasal cortical floor, right? So we don't have to waste our implant. We have to just go in once. We do the implant, and we will for sure get the anchorage. Like the way you were suggesting that we go with a smaller diameter implant and then we don't get the torque, then we have to place the larger diameter implant. In that case, the bone has already been condensed by the smaller diameter implant, and there are already threads present in the area, in the osteotomy that we have prepared. And because of that, even when we place the rescue implant, the torque achievable is not very high. But when we are going with a basal various implant, we don't have to get in the trouble of replacing the implant and taking a larger diameter implant. We can go and place the implant in a single go because of a dual thread design.
This dual thread design actually gives us around 60% more anchorage than a normal compressive implant. So,
Sir, basically, we were talking about 60% more anchorage design. That is the tornado design. Vampire design. We have these implants, and this is a vampire design. So these are a dual thread. They are double threads running, right? In vampire, there are two type of threads. There are the primary threads and there are secondary threads. Both are knife edge threads, right? So in this case, we achieve 60% more anchorage, but the varios is entirely different functionality. So this is a
I'm
contingency
saying
implant.
about the doubt of the surgeon who was using compressive over there in that
Yes, yes, yes.
perspective.
You were sir, basically what happens is, this implant has both the basal implants and compressive implant built into one implant only, right? So what happens is, even if the cortical threads are not engaged, we will for sure engage the bone with the compressive action of this implant, right? So we don't have to remove the implant. We just place the implant once, and one of both the threads will for sure achieve the anchorage. So we don't have to waste the implant and remove the implant. So we don't have to go through the trauma of removing the implant and replacing it with another implant.
Okay.
So this is the advantage when going with the basal varios, the basal implants. Right. So we will talk. We now the next section begins. I think all your doubts might have been cleared. Any other doubt till now?
Sir, I want to ask a question.
Right, ma'am.
That you showed the various implant right now. So
Right,
if
right,
we are placing a bigger diameter various implant in the posterior region, if you are replacing
right.
suppose a molar, then how
Right.
many implant you have to place for a molar?
Ma'am, ideally, if we are, ma'am, that situation depends on the anatomy of the bone, right? What kind of anatomy is present? If you have sufficient bone height and width present, na, also, can you please mute your mic? The disturbance is coming. Right. So, if sufficient width and height is available, it's preferred that you use two narrow diameter 3.6 diameter implants in the molar region, because two smaller diameter implants are always better than a larger diameter implant, right? So
Okay,
in
thank you, sir.
basal implantology, we go with the concept of one implant for one root, right? One implant for every root we place. So
Yes.
if the bone height is less of the bone height is present, in that case, now we have to place a larger diameter, 5.5 diameter various X implant, okay, and that will anchor the bone, and we have to give a anti-rotational prosthesis. The prosthesis should not be rotatable, right? We have to make the prosthesis such that the crown does not rotate. The crown remains the torsionally fixed crown. In that case, we give a larger diameter implant and anchor into the maxillary sinus floor and give a single prosthesis over that.
Okay, sir. Can you please show me such a case like that which you have done for a single 5.5 diameter implant?
Ma'am, I will be showing in the coming slides, right?
Okay, thank you, sir.
So these are the various basal cortical techniques or basal cortical sites that can be used for anchoring our implants in the maxilla. So I have classified these into three areas. First are the primary cortices, okay. Second are the accessory cortices, and third are the advanced cortices, right? So the primary cortices are the nasal cortical engagement, the sinus wall and floor engagement, in which we include the anterior wall of the maxillary sinus, the floor of the maxillary sinus, and the posterior wall of the maxillary sinus, right? And the pterygoid engagement. In accessories cortices, we will be talking about the lateral nasal wall engagement, the palatal engagement, and the mid palatal engagement. We will be discussing this will diagram. I know it won't be clear much just by studying these names, but in the diagrams and the pictures in the coming slides, it will be very clear, right? So first we will talk about the nasal cortical anchorage. Everyone know about the nasal cortical anchorage? I can do a tabletop demonstration if anyone has doubt in the nasal cortical anchorage. Nishtha ji, can you please, you want a tabletop demonstration?
Sure, sir. Yes, sir.
Nishtha ji, can you please transfer the screen to tabletop?
I'll do that.
My tabletop is visible to everyone? Right. So, firstly, we have to understand a very important concept. The concept is, I think screen is tilted now.
No.
The concept is R1, D1, R2, D2. So this is a very important concept. So what happens is when I start drilling, okay, when I take my pilot drill and I start drilling, when I pierce the mucosa, I will land on this. This is a first cortex, right? I will land on this cortex and I will feel a resistance. And when I drill further, okay, when I drill further, what will happen is there will be a drop. Why a drop? Because I will be entering into a softer bone, the spongy bone of the maxillary anterior region. Again, after that, what will happen is I will feel again a resistance. And why that resistance? Because my drill is now approaching the nasal cortical floor, the floor of the nasal cortex right here. Okay, my drill will be approaching the floor of the nasal cortex, and again that is the resistance R2, right? And what will happen is if I continue drilling further, what will happen is I will perforate the nasal cortical, right? My drill will enter the nasal cortical. At this point I will see at what length my perforation happened. Okay, I will see the mark and I will take a scale, or I can see this by length marking also. Okay, I will take a scale and I will see at what length the perforation happened, and adequately I will choose a adequate length implant. And then what I will do is I will start torquing the implant in the prepared osteotomy. What will happen is when my threads reach the nasal cortical, they engage and I get a very good torque here. And you can see here the tip of the implant is visible. Everyone can appreciate the tip of the implant is visible in the nasal cortical floor. So in this way, I have engaged the nasal cortical floor, right? Any other doubt? Any doubt in this?
No, sir.
Okay, we will move on to next slide. Can we please switch on to the presentation again? Right.
It's there.
Thank you, Mr. Ji. Thank you. So the choice of implant in nasal cortical anchorage is we can use basal classic, we can use basal varios, or we can use a basal vampire. But my choice in this case, as I have shown you in the previous slide, is a basal varios design. Why? Because in this case, if I am using, we're going with basal classic. Okay, this is a constant diameter implant, a constant diameter implant. What will happen is if I don't get the anchorage, I have to switch on to a larger diameter implant, right? So in basal various, we have, Doctor, please can you mute your mic? Disturbance is coming. So in basal varios, what we have done is we have made a double thread design. This the contingency of using a larger diameter has already been managed in this implant, right? So what will happen even if the apical threads does not engage, the compressive threads will for sure engage. So we don't have to remove the implant and replace with the bigger diameter implant. That is why the basal varios becomes the choice of implant in the anterior segment replacement, right? This is the basal varios, and I have shown you they have two kind of threads. One is the cortical threads and these are the compressive threads, and one of these will for sure anchor in the nasal cortex. Okay, and now I will show the drilling protocol. Can we again please switch on to the tabletop? I'm sorry, I just forgot the drilling protocol is also coming, so I hurried up in between.
Just give me a second, please. Yeah, it's visible.
So in basal implantology, this tabletop is visible to everyone now? Right. So in basal implantology, the concept is active threads. Active threads.
Your video is not visible.
Nishai, can you please make it the main screen? I think it's not on the main screen now.
It is actually on the main screen only.
Okay, right. It's okay. It's fine now. So in basal implantology, we go with the concept of active threads and passive shaft. Passive shaft, right? So we can see here, this is a basal classic implant. right? So only the threads are active, the shaft is not active, the shaft is passively placed in the bone. That is why the basal implants don't cause any crestal bone loss. Why? Because we are not taking anchorage from crestal bone at all. The only anchorage we derive is from the nasal cortical or the secondary basal cortexes. We don't anchor in the primary cortexes, right? The first cortex we don't anchor. So the shaft is passive. So we have to go with a two drill protocol, right? First is a pilot drill. So what I will do is I will take a 1.8 mm pilot drill. We will perforate the secondary cortex. Okay, we will take the length of the implant, and then what will we do is we will take a 2 mm, right? Because the shaft of the implant is of 2 millimeter, right? The shaft of the implant is of 2 millimeter. This is a 2 millimeter shaft, right? So what we will do is we will place the drill, and we will not perforate the second cortex. We will just, when we reach the second resistance, we will stop drilling. Why? Because we want the second perforation to be as narrow as possible to engage our threads. Okay, what we will do is we don't perforate the second cortex with our drill. We will just reach there, stop drilling. So what we are not sure about is the osteotomy we have prepared is a 2 millimeter wide osteotomy, and the threads will be passively fitted in the osteotomy. Sorry, the thread will be actively fitted and the shaft will be passively fitted, right? Because we have not perforated the second cortex, right? The threads actively engage it, and because we have done a 2 millimeter wide osteotomy for a 2 millimeter wide shaft, there is no bone compression around the implant in this area. So there is no crestal bone loss. And also, in addition to that, there is also another advantage. I will be showing this in a mandibular model because I don't have a maxillary model for such a problem. Is the buccal wall defect, right? We have all seen cases when we extract the teeth and there is a buccal wall defect, and some doctors they prefer using a compressive implant in this case, but my preference is using a basal implant. Why basal implant? Because when I anchor the implant in this site, right, what happens is the only surface that is visible to me in the buccal defect is the smooth surface of the shaft. Since this is a smooth surface, this does not irritate the tissue and does not cause any peri-implantitis. In fact, the soft tissue loves the smooth titanium surface, and there will be muco-integration through hemidesmosomal connections in the future when the implant healing is complete. So in this way, that is why I prefer the in case the basal implant is not possible because I am not able to anchor my implant into a basal cortex, if by due to some anatomical reasons I am not able to perforate second cortex, like a accessory tooth is present that is unerupted or anything like that, then what will I do is I will go with the compressive implant. Like I will show you, this is a basal cross design. This is a compressive rough surface implant. There are some cases like there is an unerupted teeth present in this area, so in that case the perforating second cortex is not possible without extracting that teeth. So in this case what I will do is I won't be performing the secondary perforation. What I will do is I will just prepare my osteotomy just short of the anatomical feature and place a compressive implant in this region. This is a basal pros compressive implant, right? This also has a dual thread design. We will be studying this in later slides. So any doubt till now? My tabletop is on. If anyone has a doubt, I can just demonstrate it right now. No doubts? So we'll be moving on to the next slide. Yes, doctor?
No doubts. Thank
No
you.
doubt. Right. So can we switch on to the presentation again? Right. So I have explained the drilling protocol. That is a two drill single perforation of the second cortex protocol.
Dr. Chitranj, can you please stop sharing your screen? We can continue.
When the screen is, I think my slide is not visible.
It is visible.
Dr. Chitranjan Chaturvedi's slide is, he is sharing the screen. Dosu, can you please click on the stop sharing? There is a icon on the lower left corner. Right. Thank you so much, Dr. Chitranjan. So I have told you about the implant length selection. Important thing was left. Let me tell you on this slide. Okay, the implant length in the basal implant is from the base of the abutment till the apex of the implant, right? The implant selection is very crucial. The whole length of the implant is considered in this catalog length. If there is an implant, say 3.6 by 20, okay, 3.6 by 20, so 3.6 will be the diameter and 20 will be the length. But what is the length? Length is from this area, it's visible to everyone, I changed the color, will be from this area to the apex of the implant, right? So there was a question. I forgot the name of the doc that asked the question, that he did the case today only about when the knife edge ridge. Okay, sir. So when knife edge ridge is present, na, that is the beauty of the basal implant, that the shaft is totally passive and it's smooth surface titanium shaft, right? So we don't. The shaft is not necessarily to be intraosseous, right? We can place the shaft outside the bone also. So in this cases, we go with the alveolar bypass technique. What we do is we don't go with the crestal approach. We will not start drilling at the crest. Okay. What we will do is we will start drilling palatally, right? We will start doing paratary, then engage the nasal cortical fluid. In this case, na, because of the knife edge, we can bypass the knife edge ridge, and also the angulation of the implant also corrects itself. Implant is in a prosthetically ideal position for the placement of the teeth, and in this case, na, we don't have to bend the implant. So the bone fracture and losing of the torque is avoidable. Right? I hope your question was answered, doctor. You asked about a central lateral question. So in this case, na, because of knife edge ridge, start osteotomy a little palatally and towards a nasal cortical fluid. Because this is a smooth surface shaft, this does not need to be inside the bone. This can be inside the soft tissue or even inside the patient's mouth. It does not matter. It will be self-cleansing, and there will be muco-integration. The soft tissue over the shaft will adhere to the shaft, okay, and there is muco integration through hemidesmosomal connections. So this won't pose any problem in the future. Any question in the alveolar bypass technique? If you want a demonstration, I can also demonstrate to you on the model also. Is everyone clear about the alveolar bypass?
Yes, sir.
Hello, sir, please demonstrate if possible.
Can we please switch on to a tabletop?
Yes, sir.
Let's go through the demonstration.
My tabletop is visible. So if this was a case of a knife edge ridge, right? If this was a case of a knife edge ridge, what we will do is, instead of going at the crest, okay, instead of going at the crest, I will place my drill a little palatally, right? I will place my drill a little palatally, and then I will start drilling. I will start drilling and I will perforate the nasal cortex, right? I will start. I have perforated nasal cortex by going palatally, right? Because there was another osteotomy done, so they both merged in it. But you get the point that we will start the drill a little palatally, then go towards the nasal cortical anchorage. In this way, the implant will also come out a little palatal side, but that can be managed in the prosthetic phase. And because this is a smooth surface shaft, so the prognosis of the implant will not be hampered with this placement. Right, so we have placed the osteotomy palatally. It's clear, Dr. Barkha, I think, asked the question to demonstrate. It's clear to
Yes, sir.
everyone. You get the point?
No, sir. Please, can you elaborate it again? I'm so sorry.
Ma'am, your audio is not clear.
Hello. My
Hello,
video
yes, ma'am.
was not clear, so sir, I was not able to start the demonstration. Can you elaborate again?
Ma'am, we will continue it further because we have to continue slide. A lot of slides are remaining. So I will answer it in the end. Okay, I will be staying. So you can stay till the end and I will answer all your questions, right?
Fine.
Any other doubt? So we
Sir,
have to.
sir, excuse me. Hello.
Right. Hello, sir.
Hello. Sir, while calculating the length of the implant, no, we have to calculate from the crest of the bone, or gingival height has to be included along with that.
Gingival height from soft tissue height, sir.
Soft tissue, okay. Thank you, sir.
From soft tissue, because we will doing this flaplessly, na. So the implant has everything. Everything has been done for you. You just have to find the second cortex and place the implant, right? Everything else has been accommodated in the design of the implant. So the length is from the base of the abutment till the apex of the implant. So whatever you do flaplessly, you do the case. You start drilling. At what point you perforate, you select the implant adequately, place the implant. And because of the because of the various implant design, you don't even have to worry about diameter of the implant, because just get a 3.5 diameter implant and these will suffice you in all the cases. But you don't have to worry about the diameter of the implant. We have taken that worry also.
Sir,
in
diameter
single
is
implant.
the shaft diameter, na?
No, sir. The thread diameter, the shaft diameter is 2 millimeters across all the implants. The shaft it is standard 2 millimeter wide shaft, and that will be 2 millimeter in all the implants. This is the thread diameter, the widest diameter of the thread here.
Okay, sir.
Okay,
sir, all implants are 2 wide, na?
No, sir. The threads are variable. The threads are 3.6, 4.6, 5.5. We also have 3 implants in the tornado design, right? So the diameter is of the threaded area. The shaft is 2 millimeter.
All implant diameter is 2 that shaft diameter.
Meter in all implants is 2 millimeter. You got the point, right? The shaft diameter in all the implants is 2 millimeter. Not the diameter of the implant is not 2 millimeters.
Okay, right, sir.
Right.
Sir, I have a question. Sir,
Yes.
in single, when we are placing single implant in the interior segment, we have to engage the second cortex also, or we can use the compressive implant of a shorter length. And
sir, देखो, in my philosophy na, the smooth surface, देखो, because basal implantology na, it derives its origin from traumatology, right? From orthopedics. In orthopedics, we don't use rough surface implants. We use them in very exceptional cases, right? And there is a presentation of my presentation on implant selection. So I will show it after this slideshow is over, right? A few slides are left. Let me complete, and then I will switch on to the another presentation that is I gave in a dental college. Okay, there was a webinar in a university recently, last week only. So there the webinar topic was implant selection. In which case we have to go with smooth surface basal implant. In which cases we have to go with in the compressive implants, because there are very strict criteria. Like I told you, in basal implantology there are rules. It's not upon us, right? We are not the ones to decide. There are indications that are pre-stated. We have to follow them, right? It's not our margi that we feel that compressive implants are good, we are comfortable in compressive implants, so we have to place the compressive implants. There are certain indications that has to be followed, right? Whenever possible, the implant should be smooth surface. When the smooth surface implant is not possible, then we go with the compressive implants, right? And I will be answering to you in the you please stay till the end of the presentation, and I will show you the other presentation also, and your doubts will be cleared to the implant selection. Any other else wants the anybody else is interested in implant selection also?
Yes, sir.
So please you drop the message, okay? And in the end, I will show a few slides on implant selection. So the preferred implant in alveolar bypass is, as I told you in the previous slides also, the basal varios. Okay. And why basal various? Because we don't have to worry about diameter of the implant. One of these, the two threads will always engage. Either we will engage by the cortical action, or we will engage by the compressive action, right? Surgical technique I have demonstrated. Dr. Barkha's screen was, I think, not visible. So I will demonstrate in the end. Okay, again, if anybody else want to see the demonstration again, they can stay till the end. And another is the primary anchorage is the anterior sinus wall engagement. We have to engage the anterior wall of the maxillary sinus. Since this the anterior wall and floor are very thin cortical area, the density is very good. The bone quality is D1 or D0 in fact in some cases, but the bone is thin. Okay, the bone is thin. In that case, now the choice of implant becomes the vampire implant. Why vampire implant? Because vampire has two kinds of threads. Okay, this is a very aggressive implant, and it's the highest torquing basal implant till reported. It has 60% more anchorage, more than 1.5 times the anchorage of a normal basal implant, right? So in these compromised cases, like we have to engage a very narrow, very thin, or very osteoporotic bone, we can switch on to basal vampire, right? This implant is very good when engaging the sinus areas. And pterygoid implants, so we have talked about in the pterygoid implants in all the cases of segmental repairs as well as full mouth repairs, right? So the pterygoid implants are there are two variants in pterygoid implant. One is a single pterygoid implant, that we place a single pterygoid implant, but in certain cases, like I told you, the sinus are pneumatized and the two implants in the anterior region are not possible, then we have to substitute with it with a double pterygoid implant, right? So when we are placing a single pterygoid implant, we will be placing a basal tornado implant. Like this is the basal tornado. This is a smooth surface compressive implant exclusively meant for pterygoid region. The name also significant. We also named it tornado because it was meant to anchor the pterygoid bone, right? And we will place a this implant. And if we have to place two implants, now we have to go with, because this is a wider implant, right? Because when we are placing double pterygoid, we have to place a narrower implant, so then we have to go with a various design. Why various and why two? Because if we place a single various, now these basal implants are isoelastic implants. So the prosthesis, though will be properly done, there will be no detrimental effects, but the stability of the bite will not be there because of the isoelasticity of this implant. Okay, because whenever the load is applied, the shaft will have certain flexure in it. To counteract that, if we are placing a segmental repair, if we are placing a single implant only in this region, we will place double pterygoids, right? It's clear to everyone. Any doubt in this slide? Right, so we move on to the next slide. So I just told you the choice of implant is either a basal various, and if we are placing a single pterygoid implant, always go with the non-isoelastic implant. Always go with a basal tornado. Accessory sites. So important note एक मैं बताना चाहूंगा. I want to tell everyone about an important note. These sites are only load dispersing sites. Okay, these are not load bearing sites, right? and not to be used as standalone implant placed in these sites. What are these sites? These are lateral wall of the nose, okay, palatal engagement and mid palatal engagement. So these sites are accessory sites. The only use of these sites we have is to reduce the inter-implant distance between the last implant of the anterior segment and the first implant of the posterior segment, to reduce the jumping distance. Due to some reasons, if we are not able to place 6 implants in the premaxilla, 3 on each sides, if we are able to place only 2 implants on each sides, then we have to place a accessory implant, one on each side, to reduce the inter-implant distance, right? These are always to be splinted with the primary implants, like the nasal cortical and palatal implants, and function is to reduce the inter-implant distance only. We will studying this one by one. In lot of cases, if in anterior segment the 3 implants are not possible, we are only able to place 2 implants in the anterior segment. What we can do is we can place in between the anterior segment and pterygoid implant, we can place a implant in the available bone in the palatal side of the socket, right? There is always, most of the time there is some bone present in the palatal aspect of the socket. Okay, if this is present, then we can engage a implant bypassing through the sinus. Okay, this is a transsinus nasal wall or transsinus lateral palatal bone engagement, and the implant of choice is always a basal tornado. In addition, basal varios can be used. Why basal tornado? Let me explain you. Because in this site now, when we start drilling, okay, when we start drilling, let me just show you. When we start drilling, what will happen is we will make osteotomy. When we insert the implant, okay, when we insert the implant, what will happen is the implant will come from here to here in the sinus. Okay, in the sinus, when the implant threads are entered the sinus, we become lost. We can never locate the secondary perforation, right? The location of secondary perforation always becomes difficult. So in this case we use a tornado design. Why? Because this is a completely threaded design. There the whole intraosseous segment is threaded. So what happens is, once we insert the implant, it will always trace the original osteotomy, and even when we enter the sinus now, the osteotomy, the second perforation is not lost. We don't have to worry about locating the secondary perforation. That is why whenever you doing with the transsinus implant, go with the tornado implant. Secondary perforation location becomes very easy, just becomes a cakewalk, right? This is the palatal engagement. When the palatal bone is present, here you can see a quite a good width of bone is present. So I can anchor my implant in this bone, or I can go through this bone and anchor the lateral wall of the nose, like I was doing in the premolar area. Okay, I will bypass this sinus. The sinus I will not enter. I will enter through the palatal bone and engaging the palatal bone and the lateral nasal wall complex. Okay, everybody clear?
Sir, can you show these anatomical landmarks on that maxilla?
Sir, this will only be visible in the CBCT.
No, sir. That maxilla you can show on maxilla.
Sir, because I have to perform. एक minute रुको. Let me see if this becomes possible. Can we switch on to the tabletop? Tabletop is visible to everyone. So what I will be doing is I will be starting my osteotomy here slightly buccally, right? Slightly buccally towards the lateral wall of the nose. It's visible. Let me position it correctly. You are able to appreciate it. Can you see the drill?
No, sir. Just take it in your center, sir.
Can you appreciate it now? This thing, the black line.
Right, sir.
Right. So what I will be doing, I will be doing the second cortex perforation also. Right. The second cortex I will be perforating the lateral wall of the nose. Okay, I perforated the drill has now entered the nasal cavity. Right. It's visible.
Yes, sir.
Anteriorly, you can also see it will be quite clear in the anterior region, right? And now what I have to do is I will have to take my implant. This is a classic design. And look, the problem I was telling you is when the threads enter the implant, the osteotomy site, the secondary side becomes not accessible. I have to locate, I have to tilt the implant becomes movable, right? Because all the threads are entered, only the smooth shaft is present. So I can anyway tilt my implant 360 degree. So the secondary, the site that I have prepared, a second perforation that I have prepared becomes lost. Like I am not able to do it properly. So in these cases, the other implant I was telling about, the tornado, becomes very viable. Okay, and I will engage it now.
Sir, it will not penetrate the sinus.
Hanji sir.
Sir, it will not penetrate the sinus wall.
Sir, that depends on the anatomy of the patient, right? If the sinus is pneumatized till the crest and there is no bone available, not even 4 or 5 millimeter of bone available, then you have to perforate the sinus. And because the other implant is also smooth surface implant, they are indicated for the sinus perforation. There will be no problem in perforating the sinus, right? So the implant is visible. Implant is visible, right? Everyone can see the implant tip in the nasal cavity. This is the implant tip, right? This, right? Everyone can see that.
Sir, nasal floor area is limited near to the anterior nasal spine only, na?
No, sir. In the premolar region also it's present. The nasal,
Okay.
the floor of the nasal cavity is accessible to all the implants in all the regions. We will be discussing in the following slides. Can you please switch on to the slideshow again? So the choice of implant in such cases is a basal classic or a basal tornado implant. Okay. Right, this was the slide. Okay, this is the mid palatal engagement. Mid palatal engagement. So we can see is we were doing the implant on the first molar area and we were not able to have any bone in that region. So what we can do is we can this bone, that is mid palatine bone, mid palatine raphe, okay, this bone we can engage going to the buccal side of the first molar. This is the mid palatal engagement, right? We can also do this also, but these are accessory implants and these are not to be used as stand-alone technique. You cannot place this implant and place a single molar cap on this implant. The implant will fail. These are accessory implants. These are only meant to dissipate the load and reduce the inter-implant distance. Also, can you please switch off your mic? Disturbance is coming. Dr. Aman, can you please switch off your mic? Thank you. So in this cases, the choice of implant is a basal classic implant. Why basal classic implant? Because of its low profile. When we are aiming for mid palatine engagement, there can be the threads might be exposed to the soft tissue. So we don't want very aggressive threads to be exposed to the soft tissue, right? When we are not sure that threads will be even submerged, the thread should always, even basal implant, the threaded part should be inside the bone. If we are not sure that the threaded part will be inside the bone, we will go with the basal classic implant because the smooth surface and the low profile of the threads can be exposed to soft tissue, right? And also we can see the threaded area is lower there are fewer threads as compared to the Varios and the Vampire design, and because the bone engaging is very less, so it's always go with lesser number of threads, and that will ensure that less number of threads will be exposed to soft tissue. So that is why in mid palatine engagement we always should stick with the basal classic design, right? And apart from that, we can also go with the zygomatic implants, right? And this is a topic of later on. We will this is an advanced topic, and this is cannot be beyond the approach of the today's webinar. We will again do a webinar whole soul on zygomatic implant, because there are a lot of approaches of doing a zygomatic implant. You can do extramaxillary, you can do equimaxillary, you can do intramaxillary, you can do transsinus, you can do flapless transsinus, you can do double window, you can do single window. Okay, there are a lot of variations in zygomatic implants, Zaga 0, Zaga 1, Zaga 2, Zaga 3. So this is a topic for another lecture. So we have an implant for this also. This is a basal vampire ZSI, zygomatic screw implant. These implants are available up to 60 millimeters in length and are very suitable for doing the zygomatic implants. So that's enough for today. So I will like to thank you all for joining me on this webinar, and I also will like to extend my thank you to the Bonenkar and team Bonenkar Implants for extending their support and organizing such a wonderful webinar today and providing these models and implants for the demonstrations. And there is an announcement. I am going to begin a few workshops and other mentorship programs. So these are details of the workshops. There will be a 1-day basal implantology workshop, okay, and that will be only for maximum 10 participants. We will be discussing the very basic and the introduction to the basal implantology. Like if you are new to basal implantology, you are not already doing the basal implants, so this is a perfect program for you. And after this program, you will be for sure enabled to restore single or segmental repairs, right? After that, we have a 3-day basal implantology workshop, and that will be for maximum 6 participants. Here we will be, this will basically, these both are classroom programs, okay, and these will include model demonstration including the pterygoids, all the theory part, how do you manage the prosthesis, right? Everything will be covered. Theoretical part will be covered in this, right? And there is an online mentorship program. You can join me for with this also. And in this mentorship program, you can send me the radiographs, CBCTs and OPGs of your cases, and I will help you discuss these cases and let you plan the treatments for them. And even in addition to that, in every weekend I will be with you through video conferencing on a video call, and I will be solving all your doubts. And in addition, if you want to see my cases also, I will share the videos with you about these. And there is also 1:1 one-on-one on-site mentorship program. In this mentorship program, I will come to your clinic and you can arrange a patient, a full mouth patient preferably, or multiple patients with less number of implants, and I will teach all the theory part, and we will do the patient the surgery part, and I also will manage the prosthetic part and teach you how the prosthesis will be done. This will be an on-site one-on-one program, and these are available in my nearby states. Since I am based in Punjab, so northern India I can travel, so I will be coming to your clinic, and there will be an on-site mentorship program. And also, if you want, you can split the fees, and I can teach the program to 3 dentists on the same clinic, right? If you want to come for in-person mentorship program, this is also available at my center also in this 1:5 module, right? So these are the various programs that I am running. Apart with, there are some fees also mentioned. So if you are interested, you can take the screenshot of this slide. This is my contact number and email address. If you are interested, you can WhatsApp me, okay, or you can also contact my contact person, Miss Asha, and these are her contact numbers. Okay, she is my contact person in Bonenkar Implants. So this is also a good program, the online mentorship program. So I will be providing all the strategic help, how to plan the cases and how to treat them, what are the sizes of the implant that you will be needing, and what are the various approaches that can be done in that case. Right? So I thank you all. And this is my contact number. Anyone else want to screenshot this?
Done, doctor.
Okay. So anyone has a doubt?
Hello, sir.
Yes, sir.
Anyone wants to wait, and don't leave yet. Wait a minute. If anyone wants to see the slideshow on implant selection, so I will be running it next. If you are interested, interested in that, so I can also run a small 15-minute presentation on implant selection. A quick recap of the lecture that I did in the university. So any doubts? We will first answer doubt, then we will move on to the second lecture. Dr. Ghazi. Hi, Dr. Ghazi. Yeah, please do it one by one. Please do it one by one.
Sir, can you explain the glabella approach implant?
Sir, this is beyond the. Can you please switch on to tabletop? Can you switch on to tabletop? So my tabletop is visible.
Yes,
Yes,
sir.
sir.
So
Yes,
sir,
yes.
this is done to be done in maxillectomy patient. The maxilla has been removed. Okay. So what we can do is we place two zygomatics on each side. We place two pterygoids in each side, right? And in addition to that, for the midline implant, now since maxilla is not there, we anchor an implant in the glabella. We anchor implant in the glabella. So this is a
Okay, understood, sir.
glabellar implant. So this is
Understood,
for
sir.
the maxillectomy patient.
Okay, okay, sir. And sir, in premolar implants, we usually engage the buccal root or the palatal root.
Sir, palatal root.
Okay,
Because
okay, sir.
buccal root has, most of the time, buccal root defect in the premolar region. So to count for that, now we go through the palatal socket, and that ensures that the bone is on either side of the implant. There is no buccal socket defect in the implant placement.
Okay, sir. Okay, sir.
Sir, can we bend the implant in the premolar region? Bending can be
Uh,
done.
the bending can always be done when using basal implants. That's the beauty of the implant. The bending
No.
can always be done.
So my doubt is, say, in case of you're engaging the lateral the wall of the sinus, as we know that cortex is very thin.
No, no, in those cases, I was talking about premolar. In sir, when you are in that cases, na, you don't have to bend the implant. When you are engaging the maxillary floor or maxillary walls, you don't have to bend the implant. You don't.
Okay. Thank you.
Implant
Thank you, sir.
bending should always be done when engaging the nasal cortical, not even in the
Okay.
pterygoids also.
Okay.
Apart
Sir,
from nasal cortical, when we are engaging any other secondary cortexes, we don't bend the implant.
Okay.
okay, sir. Sir, while bending the implant, does a fracture of implants happen, or if it happen, then how do we manage it?
Sir, it does not happen if your technique is proper ना implant does not fracture. You use good quality implants. R जो हमारा बोनेंकर का implant रहता है, that is a grade 4 titanium implant. तो इसमें fracture का problem नहीं आता है इसका.
Or sir, how to remove a old implant, or if you want to reposition the implant, how to remove these implants if they are
Fractured
properly
implant,
engaged? Basal implants.
basal implants.
So how do we remove them if sometimes we want to reposition them for a prosthetic region or any region? How do we remove them if they are properly engaged?
Sir, my tabletop is visible.
Yes, sir.
This is a bent implant. You can see this implant has been bent.
Yes, sir.
I detork the implant. I have straightened up the implant. I will remove the implant. I can again place the implant in other side. I can again bend the implant because it's a grade 4 titanium implant.
Yes, sir.
You see, I have straightened up the implant, I have removed the implant, I have again bent the implant. So the bone anchor implants are grade 4 titanium implant. So this is the most flexible titanium available and best suited for bending of the implant. You can again do it. You can again do it. I again bend the straighten up the implant. I can again remove the implant. I can do it, and I can again bend the implant. Nothing will
Okay, sir.
happen.
Sir, can
This is
we
not a
give a
problem at all.
bridge? Can we give a bridge over a conventional implant and a basal implant?
Sir, I don't prefer. I don't do conventional implants in my clinic.
Okay, sir.
I am wholly solely basal implant practitioner. The first implant I did was basal implant, and I am on basal implant since then. I did a conventional implantology course afterwards, and I have placed 40-50 conventional implants also. But my primary focus is on basal implantology. My focus and my dedication is towards excelling in the field of basal implantology only, and perfecting the
Oh,
science of basal implantology through my methodologies.
okay. So when you thought about it, if there is a previous conventional implant and we place a basal implant now, so should we, remove the conventional or do the other approach,
Sir,
or just
if I get a conventional implant ना देखो conventional implant is either ailing. You can see my tabletop.
yes, sir.
सर conventional implant ना तीन तरह का होता है. हिंदी
Yes, sir.
हिंदी चलेगी ना?
हम बिल्कुल चलेगी सर.
सर एक होता है ailing, एक होता है failing, एक होता है failed.
Okay, sir.
जिस मूवमेंट इम्प्लांट डालते हैं कुछ अमाउंट ऑफ पेरी इम्प्लांटाइटिस आ जाता है. क्यों? हमारा जो इम्प्लांट और हमारा जो अबटमेंट कनेक्शन होता है ना, वो चाहे माइक्रोस्कोपिक लेवल पे देयर इज ऑलवेज अ लीकेज. चाहे कोने का कनेक्शन यूज करो चाहे इंटरनल हेक्स यूज करो, देयर विल ऑलवेज बी सर्टेन. आफ्टर सम टाइम देखना वहां पर म्यूकोजा थोड़ी सी रेडनेस आ जाती है. तो कन्वेंशनल इम्प्लांट इज आइदर एलिंग या फिर पेरी इम्प्लांटाइटिस शुरू हो गया, थ्रेड एक्सपोज हो गया, देन इट्स फेलिंग. ज्यादा थ्रेड एक्सपोज हो गया, implant mobile हो गया, it's failed. So I always remove the conventional implants and replace it with basal.
Hello.
Okay,
Sir,
okay, okay, sir.
sir, what should be the torque while we are engaging the implant in the cortex?
Sir, approximately if you are properly following the protocol, na, you will get at least 60 NCM of torque.
Okay.
45 NCM is minimum. At 45 NCM, we can load a single implant. If we are going with a multi-implant prosthesis, then 30 NCM in each implant is more than enough. So there is a concept of cumulative torque value, CTV,
Okay.
cumulative torque value,
Okay.
right? So when we are doing multiple implants, no, we study the cumulative torque. So if we are placing
Okay.
4 implants, or the implants are at 30 NCM, so in 4 implants it will be 120 NCM. So that is more than enough for the stabilization of the 4 implants.
Okay. We have to focus on cumulative torque.
Cumulative torque, exactly. So if you are placing a single implant, na, then too you have to worry about the torque. If we are placing multiple implant, then we don't have to worry about the torque of the implant. 30
Okay.
NCM is more than enough.
Okay. Thank you, sir.
So how to fix
Any
the
other
prosthesis?
question?
Sometimes when we are using the luting agents, the prostheses are coming out. So how to fix it well?
Sir, use a zinc phosphate luting cement. Number one, my number one priority, because removing the prosthesis is very simple. Number two, if you want to use a very strong cement, you can use a resin cement in that area.
Sir, what
But
about
there
the
is a very
Yes, sir. You continue,
what
sir.
Hello.
sir, because problem with resin. Sir, please unmute your mic one by one. Dr. Krishna, please mute your mic. I will come back to you later. And Dr. Arun, please mute your mic. Okay, so what I was talking is the preferred cement is zinc phosphate cement. Why? Because if you place a full arch prosthesis and sometimes a decementation occur only on one side, right? Not on both sides, only one side. Then what happens is removing the prosthesis on other side is very simple with crown remover. You can use a crown remover, the acrograin safe relaxed crown remover, the motorized crown remover, and remove the prosthesis. But if you are using a resin based cement, you have to cut the prosthesis and then remove it. So if you want that, you have to decide you want a long term stable solution or a serviceable solution. If you want a long term stable solution, then go with a resin cement. But if you get a failure clear. You have to cut the prosthesis all in all and remove the prosthesis. But if you are using a zinc phosphate resin cement, then the removal of the prosthesis and servicing in case of chipping becomes very simple. The prosthesis can be easily removed with a crown remover.
Sir, how long does it stay when using zinc phosphate cement?
Sir, in my practice, what I have seen, sir, that depends on the adaptation of your prosthesis. The prosthesis should always be number one passive. The prosthesis should not be active. The prosthesis should fit in mouth just like this. Number one point, okay? Number 2 point, the prosthesis should always have a single path of insertion. The prosthesis should always not any time have a double path of insertion. Second point, the third point is the prosthesis adaptation should be good. You should always use the prosthetic component that you get with the implants and cast them. In that case, now the prosthesis, the intaglio surface that goes over the implant is properly adapted, and that ensures the long-term stability of the prosthesis even in case of zinc phosphate cement, right? And in my study, in my practice, what I have seen is they usually last for 2 to 3 years minimum. Afterwards there is a dislodgement, and when the patient comes, a simple one stroke of crown remover, the prosthesis will be removed. You again re-cement the prosthesis, and if there is any chipping or servicing required, you can add the ceramic, get the prosthesis glazed once again, and place the prosthesis. So while using zinc phosphate, the servicing of the prosthesis becomes very easy.
Sir, and what about glass ionomer cement? Can we use glass
Never,
ionomer
never,
cement?
never. Sir, never use a adhesive cement when you luting the basal implants. Apart from that, if the glass ionomeric cement seeps into the periapical tissue, right? There is overflow of cement in GIC. So when there is an overflow, there will be pericementitis. Around the implant, there will be inflammation of the soft tissue because of the excessive cement overflow. Overhangs, they cause a lot of trouble. So in zinc phosphate, since it's a bioresorbable material, if even if there is a outflow of the material, the body will absorb the material. Apart from that, there will be no cementitis because of zinc phosphate cement.
Sir, I have a case regarding a cleft lip patient and a cleft palate patient. So
Right.
how to proceed for that case?
Sir, you got my email ID? You screenshotted the that slide I showed you. Hello, doctor?
I've got your phone number.
Doctor Sahib, you please write me the query and then share the CBCT of the patient with me along with the clinical photographs, and I can fabricate a good treatment plan for that case.
Okay, sir. Thank you.
Excuse me, sir. Can I
Mm-hmm.
can I ask a question?
Yeah,
Sir,
sure, sir.
sin crystallization is compulsory in basal
No,
implant, right, sir?
Never.
Because nowadays we are seeing that more of the basal implantologists are doing the sin crystallization.
Sir,
Can you
basically what
elaborate
happens
little?
Sir, basically what happens is when you thin crystallize na, you can place a acrylic denture over that thin crystallized wire, right? Because
Yes.
you are not getting any casted framework or titanium framework, so the cost of the prosthesis is reduced,
Mm.
right? So that is the
Yes.
concept. So that will be very economical if you are doing just like you do a PFM bridge, right? So upper
Yes.
lower bridge, even if you get a good rate from lab na, you will approximately spend 20 to 30,000 on the prosthesis,
Yes.
राइट लैब कॉस्ट 20,000 का खर्चा आ जाता है अपना. तो
Mm.
जब स्टेन क्रिस्टलाइजेशन करते हैं तो 200-250 की वायर लगती है, ऊपर डेंचर लगता है एक ठीक है, तो अपना कितना 3-4-5 हजार में अपना हो जाता है काम बड़े इजीली. तो दैट
Yes.
इज
Yes.
इकोनॉमिकल ऑप्शन. बट सर देखो, इम्प्लांट स्प्लिंट करना है हमारे को, मेन काम है स्प्लिंटिंग का. वो आप कास्टेड बार से करो, मिल्ड बार से करो, सिन क्रिस्टलाइजेशन से करो, सेम चीज है.
Same. Okay. Thank you, sir.
Any other question? Anyone interested for the next slideshow?
Yes, sir.
Yes.
Raise your hands, please.
क्या हुआ इस बार आ नहीं रहे क्या वो?
So, shall I go with the whole slideshow or only implant selection?
Full sir, full.
Full? You want this was a one hour slideshow. So, Sarji, let us see. In basal implantology, na, we go with the no bone grafting concept, right? We don't bone graft ever. Why? Because bone grafting is unpredictable. Once the bone grafts comes in, the predictability goes out of the equation. Why? Is my slideshow visible?
No sir.
Anishna ji, can you please mainstream my slideshow? Right, thank you. So when the bone grafting comes in, the predictability goes out of the equation. So in basal implantology with Bonenkar implants, we have an implant design for each of the situation that you can encounter. Not that you will encounter, that you can encounter. We have studied upon everything, and we have a certain distinguished design. Those are patented designs for every situation, right? We have these designs. We have two classification, right? One is the partially threaded implants, these are the basal cortical screws, and one are the fully threaded implant, these are the compressive screws, right? In the partially threaded implants, we have the basal classic implant, right? In full and apart from that, there is a basal various like we have talked, and there is a basal vampire like in the previous slide, so we have mentioned. Apart from
Sir,
that, we
screen
have
is
the
not
basal
visible,
tornet.
sir.
Sir,
Sir,
screen is visible. Your net is slow, I think. So we have two compressive designs. One is a basal tornado and one is a basal cross design. This is the only rough surface basal implant available. Okay. So basal cortex screws. So basically the design ideology is same, the function is same. The main thing is what kind of bone we are anchoring. If we are anchoring very hard quality bone, like in the base of the mandible, anterior mandible region, or like we want a low profile implant, like in case of mid cortical, mid palatal anchorage, we will go with basal classic. Remainder of the times we will go with the basal various, and when anchoring paper thin bone like in the sinus area, because we will go with the basal vampire design, right? I will jump it. So they are smooth surface implants. So what are the advantages? There is no peri-implantitis. These implants can be placed in diabetics. These can be used in smokers also. Can be placed immediate extraction sockets and even in periodontally infected sockets. And reintegration is possible. If the even the implant fail, you just take out the implant, place a wider diameter implant in that. If you are using basal classic now, the implant fails. You just remove the implant, place a 4.5 diameter implant, and you are good to go. And you can even place the same prosthesis on that also, right? And these are the advantages. I will skip on to it. Hmm. हाँ जी सर, अब ये स्लाइड से देख लीजिए प्लीज. So, important note is there that the second cortex has to be penetrated and implant has to be fixed. जब basal cortical screw use कर रहे हैं, तो we are bound that second cortex has to be perforated and the threads of the implant should be engaging the secondary cortex. Right, this is very important for the success of the basal implant. If due to some reasons, right, due to some reasons we are not able to reach the second cortex, If we are not able to reach the second cortex, it is not either it is not possible, it is not desirable or detrimental. There might be chance of loss to the patient. Okay, it is not possible, it is not desirable, or it is detrimental. Then what
Excuse me,
we
sir.
will do is we will, right, sir?
I have a question, sir.
Right, sir.
Regarding this slide, you have said that penetration and fixation of implant in basal cortical is absolutely necessary.
For the basal
Is
cortical
this
screws.
yeah?
For the
Is
basal
this
cortical
statement correct for classical type or for the various and pros type also?
Sir, these are true for the smooth surface implants.
Okay, regarding of the name or regarding of the design.
इरिस्पेक्टिव ऑफ द डिजाइन सर, देखो आपने बेजल क्लासिक देखा हमारा, उसमें भी चाहिए है, बेजल वेरियोस में भी चाहिए है, वेम्पायर में भी चाहिए, और जो हमारा स्मूथ सरफेस कंप्रेसिव डिजाइन था ना
जी
टॉर्नेडो,
जी जी।
उसमें भी सेकंड कॉर्टेक्स परफोरेट होनी चाहिए, या फिर
Okay.
एटलीस्ट सेकंड कॉर्टेक्स रेस्ट होना चाहिए इम्प्लांट कि टच कर रहा हो उसको उसके अंदर जब हम टॉर्नेडो यूज कर रहे हैं। ये आने वाली स्लाइड में आएगा अभी।
Okay, तो
Sir,
ये
requesting
लाइन क्रॉस के
requesting
लिए
you to
भी
say in English, sir, please.
sorry.
Sir, can you please repeat the question?
Yeah, sir.
No,
I
no,
was
no,
saying
no.
that.
Sir, just
Yeah.
English.
Okay, sir. No issues. Yeah, I was saying that if we are going for pros, that is a rough surface implant. So can we place it in normally like we do the normal implants, conventional implants? I'm only asking for pros.
Sir, it's coming in the following slides. Let me tell you, if there is still a question, then I will answer that. I think your
Okay.
question might be answered in the following slides. Okay.
Okay.
So if the secondary cortex is not perforable, if we cannot engage our implant in the basal cortex, then we will go with the basal compressive implants, right? We have two type of basal compressive implants. One is a basal tornado, and one is the basal pros, that is a rough surface implants, right? Both have the similar design. The only difference is that this is a smooth surface implant and that is a rough surface implant. So indications पढ़ लीजिए, please take the screenshot of the indications. That
Yeah,
penetration of the opposing cortex is not possible due to various reasons, but implant apex can be rested on the basal cortex without actively engaging it, right? We can see in this x-ray also. So what I have done is, this is the floor of the maxillary sinus, right? My implant is going in and resting on it, not perforating it. In these kind of situations now, when you can rest the implant second cortex, you can use a tornado implant. And in similarly in pterygoid implant also, if you are not interested in perforating a pterygoid, because a lot of people are very scared of perforating pterygoid since there is a chance of vascular trauma, so you can go with a basal tornado implant and rest the apex on the pterygoid. You just feel where the resistance is, you select the adequate implant length and you tighten the implant up till that resistance, right? You don't actively engage the pterygoid. This is one of the way of placing a pterygoid implant. Right? And now it's basal pros. Dr. Simmer, please unmute your mic. You can participate with me in this conversation. You can take a
Okay.
screenshot of this slide also. So
Right,
देखो indication क्या है इसकी? The
So
indication
the
is,
previous slide, please, sir. Previous slide with the X-ray.
so the basal pros. Okay, so this is a rough surface basal implant. So the rough एक नोट है, पहले ये भी we will study. Either ideally in basal implantology the implant should be smooth surface, but this rough surface treatment is not a violation of the principles of basal implantology. In the spinal screws we don't perforate second cortex when we are placing the polyaxial screws in the spinal implants. So this kind of design is used, and this kind of design, the indications, dental indications we will read: if sufficient bone is available both vertically and horizontally. बोन हमारे पास विड्थ में भी अवेलेबल है, बोन हमारे पास हाइट में भी अवेलेबल है फॉर द इजी प्लेसमेंट ऑफ द इम्प्लांट. एंड सेकंड, the penetration of the opposing cortex is not possible due to various reasons, and in addition to that the implant apex cannot be rested on the basal cortex. In those cases we can go with a cross implant. Like in this case, enough bone was available both vertically and horizontally, and there was the nerve is passing through the implant below the implant, right? In this case I don't want to engage the basal cortex here, so because the base of the mandible is the basal cortex, so I don't want to engage that. What I will do is I will place these kind of implant. So in these, only these kind of implant, we take the anchorage from the spongy bone, not from the basal cortex.
Sir, in lingual cortical engagement also?
Sir, there are a lot of possibilities, right? There are a lot of possibilities that we can do. There are number of ways to solve a problem, right? So there are certain rules and regulation that we teach in our course also, that has to be followed for the ideal placement, right? So you have to see when to lingual cortical engagement. Like, can we please shift to the tabletop?
No, sir. I mean, that rough surface implant can be used for lingual engagement also.
No, sir. Whenever you are perforating the lingual cortex, never use a rough surface implant.
Okay,
and there is another problem also. Let me tell you. My tabletop is visible to everyone.
Yes, sir.
So, sir,
Make it
what
as
happens
a mainstream, sir. Make it as a mainstream.
Please reposition it. Please reposition at the center.
Nishtha ji, can you please make it the main screen? You can see I am bending the implant and straightening it again for the fifth time in today's presentation only, and the implant has not fractured. That is the quality of the implant we deliver, right? That is the power of the grade of titanium that we use. So is it visible? The tabletop is visible?
Yes, sir, it's visible.
So, sir, there is an important thing I want to tell you. Number one is, see the angulation. You are seeing the angulation of the implant.